here at the Center for Pharmacy Practice Innovation at the School of Pharmacy. I'm actually joining today from a small farm outside Kansas City, so please forgive me if you hear some ducks or other animals. I would like to introduce our speaker and then hand it off. And if you have any issues, I know there was a problem with the sign in. If you have any issues with the C or anything at any point, feel free to shoot me an email. But without further ado, I'll introduce Dr. Finks. She's here. She works at the University of Tennessee and is joining us today. Excuse me. She has practiced for 2 decades in the area of cardiology and has expertise in private institution and academic practice settings. She's a fellow of the American College of Clinical Pharmacy and has board certification in pharmacotherapy and cardiology and HSCP-CHC certifications. She teaches across multiple courses at the College of Pharmacy at the University of Tennessee with a focus on cardiovascular pharmacotherapy. She has provided more than 140 invited lectures on numerous cardiovascular related topics to healthcare professionals on local, regional, national, and international platforms. So Dr. Finks, feel free to add anything else you'd like, but I'm going to hand it over to you.
Thank you so much. I am fighting a cold, so this is not COVID. Just know that if I have to clear my throat, I'm very sorry. I am pleased to be with you. I know several of you in the audience, you've been my longtime colleagues in cardiovascular pharmacotherapy. And today I'm actually speaking about something a little bit different. And I'm going to talk about my current practice, which is a clinical pharmacy practice inside my very own with my husband's concierge medicine practice. And he likes to coin the phrase, we've built an airplane in the air. And that is the topic of our discussion today. And hopefully today is going to be very informal. I have with me my physician colleague and husband, Dr. Lloyd Finks, and I have my resident, my very first resident, Dr. Alex Carmen, with me. And so I'm hoping that at the end of our time together, there will be plenty of time to ask both my resident and our chief medical officer and physician collaborator questions about what we've done. And hopefully this can stimulate some ideas for you to develop your dream and to expand the field of clinical pharmacy into areas that may not be in existence at this point in time. I'm going to flash this claiming credit slide on board as I was asked to do. I'm also going to return to this.
Your slides aren't showing, sorry.
Uh-oh, okay,
realized.
let me see, hang on. Let me get back to the Zoom conference if I can find it. And then I will share my screen. Let's see. Can you see this now? Can you see it now?
Yep, all good.
Okay, perfect. Okay, you're welcome. I'm gonna show this slide again at the end for those of you who need to claim credit. And I was asked to obviously provide the disclosure slide. I have no disclosures to claim. Today, what we're going to do is briefly describe our pharmacy practice model that was created for interprofessional collaboration and with a flair for something contemporary and unusual, and hopefully to demonstrate how pharmacists can create a viable business model within a concierge medicine practice. And then at the end, I'd like to just identify some unique opportunities for pharmacists on the interprofessional healthcare team. And again, this is going to be very informal. I really encourage questions about what we've done and hopefully to stimulate your own interest in developing your own contemporary pharmacy practice. And when I think about where I've come from and where clinical pharmacy has come from over just the 25 years that I've practiced, it's just expanded into so many different areas. And I'll use this as an example. When I was a pharmacy practice resident, one of the projects that we worked on that year was establishing the role of a pharmacist in the emergency room. And fast forward 25 years, and at least my urban setting, there's a pharmacist in every single emergency department in this city and with round-the-clock care. And that's how I see us looking to the future and establishing practices in places where medications are prescribed all over. We have so many different areas of expertise and so much to give the healthcare industry. We have a job to do that no one else can do, and I'm excited to talk about the future. And some of what is popular today is talking about team-based care, and I do believe that this is very important, and we're going to talk about how we established a team base in my own practice area right now. And my husband's with me right now. We had planned to start a clinic together for over 20 years. He kept saying to me, when are we going to open our own clinic? And I was kind of a little bit headstrong. Maybe I still am. And I really enjoyed cardiology practice. That's what I was doing. I wanted to develop my expertise in that area, and I wasn't ready to step out yet. But we always had talked about our dream, our wish list, if you will, and we knew that we wanted to collaborate together. And when we started to really hash out what was going to be on our pro forma and how we would wish to practice, the two very key aspects of clinical care that I knew that a pharmacist could bring was to establish a comprehensive medication management program and to incorporate pharmacogenomics somehow. And we'll come back to both of those again before the end of the talk. But I think these two aspects make us unique, and at least in our geographic area. And I think it's something that pharmacists can own and bring value to the patient. My husband had spent the first part of his career as a hospitalist, and then towards the end of, before we came over to our concierge medicine practice, he was an administrator over the urgent care practices for a major hospital system in town. And he knew how the urgent care environment worked, but what he noticed that was a problem was that someone would come in for an urgent care visit, they'd be seen really quickly, but they would be found to have hypertension or diabetes and not have a PCP, and not be able to follow up with someone in his hospital setting until 6 months later, which is really a time frame where you lose a lot of that continuity of care and good evidence-based medicine. And so we actually wanted a hybrid. We wanted both an urgent care and a place where we could bring those patients back in for primary care, those who did not have PCPs or those who wanted to transition their care to us. And we wanted to offer a one-stop shop. So part of my goal or practice is to manage our dispensary. We have about 100 different medications in our on site, where they would be short course medications that we outsource. We don't fill, but we dispense. And this has drastically improved our patient satisfaction, as well as establishing fast and care for that individual who comes in who's not feeling well, because the last thing you want to do is go to a major chain and wait several hours after you've been seen by the physician. We also, my husband comes from a background he went to Cornell, and that concierge approach, that hospitality management was very important to us. And we wanted, you know, from your own experiences, that hospitality is missing from medicine, and it's not a fun experience to sit in a very large waiting room and be under the weather and have to deal with signing paperwork and not being called in an efficient time frame. And so these were our wish lists. We wanted to be very intentionally different from other medicine practices. We had to be very efficient with both time and our resources, and we wanted to practice radical hospitality. And so I could tell you all about our clinic, but what I'd like to do right now is actually show you a video. And this is our story at ZüpMed. And bear with me just a second. Can you still see this screen?
Yes.
Okay, great. Let me find our video. Here we go.
We knew in our hearts that we wanted to be intentionally different. because
We can
it's
hear
time
the
for it.
video, but we can still see just your
Just
slide.
all start.
Okay, hold on. New share. Here we go. Thank you.
There we
With a
go.
conversation over a napkin.
Great.
What do we like? What don't we like? And that's the start of grabbing things that work, but also finding ways to eliminate the things that don't make any sense.
Because of our experience, we knew that we could do things differently.
So we created ZüpMed.
ZüpMed is a hybrid between an urgent care facility
And primary care.
as well as modern treatments and holistic care.
Through our concierge setting, we're bringing white glove medical care whenever and wherever you need it. What we're trying to do is to combine the very best of Western medicine
And take the inefficiencies and try to improve upon them.
and bring that through an unmatched patient experience. We are a full-service medical clinic staffed by the best.
And every single one of us is committed to giving you a 5-star healthcare experience. It's the philosophy of how we care for people that matters to us.
Our job is to bring comfort and healing as best as we possibly can.
We think this environment does just that.
When you walk in through the lobby, which doesn't have a waiting room because we don't believe that waiting rooms are either efficient nor smart
We don't like waiting.
at all, none of us do, you're going to be greeted by name.
Welcome to ZüpMed.
Our concierge is going to walk you back to the exam room that has been reserved for you. You're seated in a comfortable zero-gravity recliner, and the next person you see will be the provider who's taking care of you.
We value your time, so we focus on our efficiency. You need to be seen, but you also need to make that 2:30 meeting or pick up the kids from school.
We're going to get you there. Other clinics cannot make that promise. We also have a very modern digital X-ray. More important than our modern digital X-ray is the person behind that camera.
Thanks for coming into Zup. I'll send your x-rays right over to your room.
We at Zup are intentionally different.
Like the way patients have access to our services. You can experience the Zip difference by simply making an appointment online or speaking with our concierge. We'll charge you only for the services that you need. But Zip membership is also available for a very reasonable monthly fee that provides 100% of their urgent and primary care visits throughout the year. You'll only be charged then for extras like lab work or x-rays.
There are many reasons why we don't take insurance, but quite simply, that decision has allowed us to provide this level of care. Younger individuals that may have to pay that very high dollar premium to go see the doctor, they avoid going to the doctor because of it. And yet for less than your cell phone bill, typically a month, it just makes sense. Plus, most patients can still submit what they've paid for to their insurance company for reimbursement.
From the time you call us, we want to begin forming connections with you as the patient. The beginnings of the key to the concierge service is to identify the individual and their personal needs. Some of us need to get in and out very quickly. Some of us need to talk for a while. But there's no doubt the more information that's available, the better decisions we can make. So ZüpMed is fully equipped with our own laboratory.
And the last thing that you want to do when you're not feeling well is have to go somewhere else to get your prescription filled. So instead, we have a small dispensary and can dispense for you a short course of medication. So there is no going to another location.
These are all things that we believe you should expect from your doctor's office.
It was a pleasure taking care of you today.
If you feel better when you leave, then half the battle is already won.
Mhm.
Okay, so let me see if I can share my screen again with my slides. So, oh goodness, hang 1 second. Let me go back to this. Okay, so that's our story. And toyed with this for a long time before we decided that the concierge medicine route was how we wanted to go. And you may not know this, but concierge medicine started in the 80s with the Supersonics out of Seattle. And there were two physicians, and I believe they were called MD squared. And they had this idea that they would be the personal team doctors and that all they would take care of were about 50 patients. And it would drastically improve their quality of life in terms of physician number of patients seen daily. But this came at a price. And at the time, this cost the average supersonic player about $20,000 a year. Since then, there are large groups of physicians that have joined national chains of concierge medicine. MD VIP is one of those that's national, and you don't pay $20,000 a year. But the idea is that there is an annual retainer for someone who wants that extra level of relationship with their provider. They want to be seen same day. They want that priority, and they want their doctor to know them rather than the typical experience that you're in and out. And if you don't have your questions written down, you're going to not see them for a quality amount of time. On the flip side, concierge practice has been very popular among physicians because of burnout and stress, and moving to a concierge model allows the provider to see less patients per day or year, and there's greater professional satisfaction. And along with that extra time, there is a higher level of care coordination. And this does come at a cost. That's the major disadvantage. Depending upon where you are in the country, we estimate anywhere between $1,200 and again, that $25,000 fee out in San Francisco or in the DC area. And so this is not for everyone. Concierge medicine is driven mainly by two forces, and that's number one, patients who desire a better service experience from their physician and they're willing to pay for it, and then doctors who are dissatisfied and very happy to make the move to actually a higher salary with seeing fewer patients. But as my husband likes to coin the old Wendy's commercial, it's where's the concierge in this? And I think that what we've tried to do is make this an experience for our patients that is worth the dollars that they are spending. According to Get the Medications Right Institute, the average physician spends about 15 minutes with a patient, and only 38 seconds per visit is spent on any new medication. So this is a huge area of opportunity for a pharmacist to be in a physician office where medicines are prescribed. And maybe that physician doesn't spend 38 seconds, but the pharmacist spends, like in Alex's, in my case, 30 minutes if needed. 45 minutes if needed, 5 minutes if needed. And it's very personalized. We bring to the table too pharmacogenomic information. And in planning to incorporate pharmacogenomics, I only knew of 3 meds because I was coming from a cardiovascular background, and I thought, maybe I'll use pharmacogenomics. But fast forward to COVID and the mental health crisis in the United States, and we use pharmacogenomic information every day to make sure that patients' mental health medications are right. And it's been a huge benefit to reducing the trial and error approach to medicines that our patients are typically experiencing or have typically experienced prior to coming to us. I'll talk in a minute again about how we're incorporating comprehensive medication management, but pharmacists need to own this. And there are major groups working to get payors to ensure that pharmacists are placed appropriately into offices and reimbursed appropriately for our expertise, because we can make a difference in patient outcome by spending the time that's necessary in coordinating all of these medications. For us, one of Alex's, my pharmacy resident's job descriptions is she manages is our dispensary. And you would be very surprised at how many medicines we go through on a week. So we're ordering constantly to keep both our OTC supply and our prescription dispensary stocked, because that's a very valuable experience for our patients. And finally, we also are a bit integrative with our approaches. We have lots of patients who are very interested or who are already taking supplements, multivitamins, micronutrients that we tend to screen and incorporate and make sure that it's safe. And even with some pharmacogenomic information, we can recommend some integrative options for patients with certain phenotypes. That's been very exciting for me personally. So when we were planning to open our clinic, we had no idea of this little virus called SARS-CoV-2. And in fact, we had planned for a couple of years prior to even starting construction on our clinic. And just like any home building project, there are construction delays, and it was not out of the norm. We had delays, and we were supposed to open in July of 2021, and then it was October, and we finally got our certificate of occupancy on March the 20th of 2020, and our mayor shut the city down exactly 24 hours after that. And I remember distinctly the very first patient that walked through our door on March 2020 was on lithium. And I got really excited. I was like, oh my goodness, this is gonna be fantastic. I'm gonna get to monitor every patient. And then when the mayor shut the city down, we looked out at an empty parking lot and thought, uh-oh, this is not so good after all. And I think from any small business owner's perspective, you have to be able to shift focus very quickly if it's not going in the direction that you anticipate it to. And so both Lloyd and I decided very early, in fact, that day, okay, well, PCP offices are shutting down. We've got to become a COVID care center. We need to educate ourselves on whatever we can get our hands on testing, on treatment, on referral for monoclonal antibodies, all of the things. And we built our reputation, actually, we cut our teeth, if you will, on COVID. And we did not know if we would fly, but we have built an airplane in the air, and we are lucky that we used COVID as a platform to introduce ourselves to the community. It was the best open house that we never could have paid for. And I know that not everyone can say that, but we are very grateful for that, that timing. So we started out with just the physician, the pharmacist, and 2 front desk concierges. And we quickly grew because of COVID to a staff of now 15. We have a physician on staff. He is our chief medical officer and co-owner. We have 2 nurse practitioners that are providers. We have 1 clinical pharmacist. We all have collaborative practice agreements with scopes of practice. And I have a pharmacy resident who we added in January. We have a nurse and an intern. We have 2 X-ray technologists who also function as medical assistants. In the summer months, we have lots of high school or college pre-med students who like to rotate with us. We have intern positions as medical scribes for them. And this summer, we currently have 2. And then we have 5 front desk people who work either part-time or full-time, and they alternate with each other. And so we've grown very quickly into this intercollaborative team. And we're very, very fortunate. And because CE is associated with this talk today, I'm going to briefly mention a couple of things that I'm going to ask questions about. And the first is the collaborative practice agreement. I'm sure you guys have talked about this before, but a collaborative practice agreement is not essential for a pharmacist to function in a team-based care setting. However, it is a vital tool for efficiency. If you don't have a collaborative practice agreement, then there's lots of phone calls back and forth, or there's lots of going back and forth with the physician. And if you have that scope of practice in place, it makes things run very efficiently and smoother. And I would highly recommend, if you are establishing or thinking about establishing a team-based program, that you look into establishing that collaborative practice agreement. I've included in this slide set, and I'm not sure if you'll have access to the slides themselves, but there are several resources for collaborative practice agreements out there. The CDC has several, the National Alliance of State Pharmacy Associations, and then my particular state has a section on their website, on the Tennessee Pharmacist Association website, but I'm sure your state has similar resources as well. And that's another talk all in itself, but because I'm asking a CE question on what is a CPA, thought I would mention just those high points. This is how our clinic kind of works. So a patient will call, a concierge will answer, they will determine what the patient needs. Most of our urgent and primary care is seen first by our nurse practitioner. If a patient is calling about a medication management issue or a genetic test or something where we are already seeing them for medication management, either hypertension, diabetes, thyroid, those types of disease states, chronic disease states, they'll be seen by either myself or Alex. Our emergency or complicated visits are seen by our physician. Our MAs and our nursing staff are utilized in point of care testing, lab draws, assisting our nurse practitioners and providers throughout the day. Our pharmacists are involved in point of care testing. And I think this is really, I think this is something that can also be taken outside of a physician office. There are pharmacists that can establish point of care testing protocols in pharmacies in the community, and COVID is a perfect example of why that is needed. But we do point of care testing for many acute care illnesses, typical of what would bring someone either into a minor med or into the physician office, and we manage those appropriately. And additionally, coming from the cardiovascular background that I did, I wanted to establish a cardiometabolic risk clinic. We're looking into weight management, lipids, obesity, inflammation, those types of things. And most of the time, these patients are seen by the nurse practitioner as well as Alex and me. And Alex and I will monitor those labs and look for opportunities to achieve blood pressure goals, lipid goals, weight goals, et cetera. We're also called constantly to recommend drug therapy, either in OTC format or supplement use or prescription medications. And every time I walk out front, I am asked a question by a patient, or we're called constantly into the rooms when there's a drug issue and our nurse practitioners need our help. And so we're involved in not only dispensing patient counseling, but also in drug therapy selection as well, which is just a wonderful way to use our license and practice at the top of what we were trained to do. I'm a big believer in CMM. I am a signing member of Get the Medications Right organization, where we're really trying to elevate the patient care experience and the medication use experience, and to reduce the medication waste that occurs in our country. And there are comprehensive medication management is a whole talk on itself. I just wanted to direct you to sources where you can learn more about CMM. If you are practicing in primary care and want to incorporate this model, there are 10 steps. We're trying to establish a standard of care so that it is practiced in the same way across the country. And I will put in a plug for, there is an ACCP program that is going to be launched in July of 2022, talking about implementing comprehensive medication management in your practice. This is designed for us as clinical pharmacists or administrators, clinical pharmacy administrators, to improve our knowledge enhance our integration into primary care offices and to expand CMM services across our country. And this is a self-paced program over 1 to 2 years. Pharmacogenomics is another aspect of pharmaceutical care that we incorporate here at our clinic, and I believe that pharmacists have to own this, and if we don't, we're missing a huge opportunity. Like I said, before the pandemic, I thought, well, I might use this occasionally, but I don't know how it's going to become a daily part of what I do. And since COVID, and since we have such a large number now of patients who come to us because they're dissatisfied with either the lack of effectiveness from antidepressants or anti-anxiety agents, all the way to, hey, you know, I already have a genetic report, but nobody knows how to read it. Can you help me and make sure that I'm getting the right medicine at the right time, at the right dose, and I'm the right patient for this? And I think that this has been absolutely fascinating. You need proper training in this area. There are several programs that offer certificate programs in pharmacogenomics, but I think at a bare minimum, it is a must for you to understand this. It's just another piece, just like a pharmacokinetic information that we need to incorporate into optimizing our medical care in our patients. So the pharmacist at our clinic, I think is innovative. I hope it is. I think for me, the personal satisfaction is that I'm practicing at a base, just like I would if I were in an inpatient cardiology setting or on any team that I've ever practiced on before. I'm looked to provide drug information. I'm looked to develop evidence-based protocols and to make sure that our patients are achieving goals from an evidence-based perspective. But I also get to practice as a community pharmacist, which I had never done prior to establishing this clinic. We're coordinating vaccines. We are doing dispensary management. We're communicating with that patient in almost a retail setting if we're talking to them out front, and then in a patient office setting when we're talking to them in patient rooms. And it's just highly professionally rewarding to me. And then finally, with our collaborative practice agreement, our scope of practice, we're practicing at the top of our license as a provider in offering both pharmacogenomic and comprehensive medication management care. I think there's value added, and I think that of course, we know that we add value to medication histories and allergies. Not that our interdisciplinary team can't do it, but we know to anticipate the types of questions, or we're thinking ahead because of our knowledge in medications. And we can take that time when we're doing a history to look for refill and adherence monitoring. It adds an extra layer of achieving those goals. In our current practice, there's quicker turnaround for drug-related portal entries when patients enter in medication problems. We're on it. We help take care of it. I'm amazed at my residents' ability to function in achieving prior auth as well as doing something at the same time. Alex practiced in a chain pharmacy for about 6 months before she came on board with us. And she's just invaluable in terms of understanding from the retail end what barriers are in place when we prescribe something in our electronic medical record. And she can solve so many problems that I can't live without her, actually. We are constantly answering drug-related questions. We're in charge of our vaccine program. We're integrated into point-of-care testing. We're monitoring and surveying that drug response, and all the while hoping to improve that value that only we as a profession can add. And I'll throw this up here. I'm going to come back to this in just a moment. The big elephant in the room is, how are you reimbursed for these services? And I'm not exactly sure we have it right yet, but I'm going to speak to that because that's a huge part of establishing a pharmacist team-based care program. You've got to be able to feed yourself. You've got to be able to pay for your services. And I'll come back to that in just a moment. But our pharmacy practice at ZüpMed, our clinical function and knowledge is very similar to any other clinical pharmacy practice. Our billing is interesting. We are not currently, and this is subject to change, but we're not currently basing our pharmacist salary or our resident salary on patient visits per day, but we're actually using a hybrid approach. We are seeing some patients and bringing in income, but we also value those additional functions that aren't reimbursed by Medicare, and know that though that the patient experience is elevated and we're achieving better medication optimization by utilizing pharmacists in our clinic. And I will say that, you know, this is complicated. Pharmacists as providers require meticulous billing, and that's one of the reasons why we as a concierge practice decided not to file insurance. And you can ask us questions about that at the end of the presentation, but it's messy and it's complicated, and we're not sure that it's the right answer, but it's working for us right now. And that's as far as I'm going to say. When we first started, it was very difficult to figure out what the average reimbursement was for a provider visit. And I'm just showing you some example. I think it's a little bit easier today to find average reimbursement rates and what a pharmacist can bill for if you have a scope of practice and a collaborative practice agreement. But these are things that we were working on when we were developing our pro forma, in terms of how are we going to pay for this, and how many visits per week do we need to achieve in order to justify this salary. And again, we are not basing the pharmacist salary completely on reimbursement dollars, but maybe a part-time. So we need to see 24 patients a week in order to justify a part-time pharmacist salary. And then we utilize those other functions as value added. The two groups that I know that are working and that have major pull on a national level for reimbursement for CMM and reimbursement for these types of services utilizing a pharmacist is Get the Medications Right Institute. And I encourage you all to become a member, because this is going to secure our future in all areas of practice where medications are prescribed. But we're also partnering with the Primary Care Collaborative, who are our physician colleagues who very much want our help, very much want our team approach to managing patients in the primary care arena. So I'm going to kind of sum up for you how I ended up in where I am, and just thinking about your own model. And then we'll go through some CE questions, and then it'll be time for you guys to answer or ask questions of us. But number one, this has to be your dream, and your dream can be based upon 25 years of experience in another area, or it can be 6 months in an area where you are not professionally happy. And you need to, all it takes is identifying a gap in care that you can offer. Ours, we thought, was radical hospitality, which it probably is going to grow into after this, after we come out of COVID, but it ended up being, we offered a niche that in our area, no one else was really doing expert COVID care. And we're thankful for that gap because it put us on the map. You have to make this your own. Our clinic is uniquely my husband's and mine. It is our personality. Our staff are very much used to our quirkiness and our expectations, and our clinic we're proud of, and you need to be proud of what you're doing. And you can do this. The team-based approach, though, with a collaborative practice agreement, I think is the way to go. And I know there are some pharmacy providers, clinical pharmacy providers, that are out on their own in consultation businesses. But I'm going to tell you that if you do have a partnership with a physician collaborator, it just makes things so much easier. You want to, when you're developing your CPA, you've got to develop that scope of practice, and it needs to be, you start small and then it can grow. Once your physician develops confidence in you, you can extend to other areas. Ours really started with COVID and some cardiometabolic monitoring, and it's since grown to include pharmacogenomics and those antidepressant, anti-anxiety, ADHD meds. So it is not stagnant. It can grow, and you can go back and revisit that. And state laws are different between states, but there will be a periodic term where you will need to re-sign your collaborative practice agreement. I think for marketing standpoint, you need to target a certain patient group. Don't say, hey, I'm offering pharmacogenomics, here I am. They're not going to come to you in that way. Like, find a niche. Are you unsatisfied with your anxiety and antidepressant meds? Are you struggling with cancer chemotherapy? Are you overweight and need help with cardiometabolic risk management? Target a patient group, and then you really do have to invest quite a bit. I was shocked at how much we spend in terms of advertising, but those dollars, that you do get a return on your investment. I think that, like I said earlier, you have to make sure you can feed yourself. You don't want to quit your job without knowing that you've got some income coming in, and the sky's the limit in terms of how you adapt and make this happen. But and speaking of adapting, you want to be able to adapt very quickly, because that's going to keep your business sustainable and your partnership sustainable. I think my husband would say you have to be persistent to your end goal, and you don't need to stray very much from that one end goal. Our end goal, I mean, we could do all kinds of things. Patients come into a concierge practice and ask us to do so many different things. And sometimes we can accommodate them. And then sometimes we have to look back and say, you know what, we just cannot do this for you. And I think that staying true to what is in our wheelhouse is better for patient care. And that is what we are trying to do. And lastly, I would say that in just like you guys are doing today and sharing information, you've got to collect data on what you're doing and share it, because it will help our profession as a whole. I like this quote, teamwork, and the last part of this quote is, teamwork is the fuel that allows common people to attain uncommon results. And we're in a time frame where we can integrate as a profession unlike we have never before. And I hope that it doesn't take 25 years from now for us to say, what's the role of the pharmacist in every area where medications are prescribed. I hope it only takes 10 years from this point, and maybe 5 years from this point, but teamwork is the way to get there, and collaborating with our interprofessional colleagues is the way to go, in my opinion. I'm gonna highlight 4 CE questions, and I'm not sure if your other speakers have gone through each one in depth, but I'm gonna fly through these so that we have time to answer any of your questions that you may have. But is concierge medicine a hybrid between urgent and primary care? Is it an expensive service only afforded by the upper class? Is it a model that improves both patient and provider interaction and satisfaction? Or is it a medical practice that includes a pharmacist? And I'll give you just a second. Obviously, and I'm not sure if I'm supposed to give you the answer or not, but it should be an obvious choice there. The comprehensive medication management process includes all the following, except ensuring patients' medications, including prescription and non-prescription medications, are individually assessed. It includes individualizing a care plan with appropriate follow-up, and it includes optimizing each patient's medication experience and clinical outcome. Or does it include participating in the P&T process for medication monitoring? Question number 3, reducing the trial and error approach to medication prescribing can be achieved through medication therapy management, pharmacogenomics, pharmacokinetics, or disease state management.
You can give folks the answers once once you've
Oh,
given
okay.
her time to respond.
Okay, sure. So let's go back to question one. Concierge medicine is a model that in theory improves both patient and provider interaction and satisfaction. Number two, comprehensive medication management, the 10 steps of comprehensive medication management does not include P&T. And reducing the trial and error approach to medication prescribing is done so through pharmacogenomics. And then our last question is, a pharmacist is participating with a physician on achieving blood pressure control in a primary care office. Which of these models is the most efficient use of resources given that appropriate training has occurred? Is it establishing a collaborative practice agreement between the physician and the pharmacist? Is it the pharmacist calling the physician office if the patient's blood pressure is not at goal at the time of refill? Is it that pharmacists are given a list of the practice's hypertensive patients and asked to call them? Or is it offering the patient a referral number to discuss medications with the pharmacist? And obviously, I'm hoping that you chose option A on this. So the sky's the limit for you guys, especially you guys in the audience that are younger and residents and thinking about your future and how you want to change clinical pharmacy practice in your lifetime. I've given you an example from a paper using a CPA in hematopoietic stem cell transplant patients. I hope to publish our experience or something about our experience in an urgent care environment. You really have so many different options to make it your own and to break down these barriers and integrate practices where we have not before. Excuse me, with that, I made it through without coughing. With that, I'm very happy to introduce my husband, and I'm going to turn this is Dr. Lloyd Finks.
Hi, guys.
And this is my pharmacy practice resident, Dr. Alex Carmen.
Hi.
And we would love to answer any questions that you may have. I'm actually going to let them sit together. And I'm going to move over here so that you guys can ask them questions.
As we deal with Shannon and her tuberculosis.
Well, this is fantastic. Despite any illness, this is wonderful. Thank you all so much for sharing. I think we did have one question further up already in the chat. Let's see here. Thanks for the presentation. Tyler Wagner says, I just wanted to confirm, but the service aspect of the clinic is cash payment, but the drug/pharmacy aspect is both cash payment and insurance, and thus why you're still dealing with PAs. Do you prefer patients to use cash for some drugs because of DIR fees?
So our dispensary is at our clinic and we only take cash for those. I'm dealing with PAs for prescriptions that we send out that we're not able to stock the drug here for expensive things, brand name drugs, new drugs that we have to send somewhere else. I work with the nurse practitioners to get those PAs pushed through. But as far as our clinic, we only take cash.
We try to optimize our service for our patients. And in other words, although we are cash-based, if our patients have insurance, we try to allow them to utilize that as much as possible. So it not only extends to pharmaceuticals, but also to lab and x-ray services, for example, that we might not be able to provide here. Insurance will often pay for those patients to get it somewhere else. And so we help them do that. You know, one thing I wanted to mention, just to carry on with Shannon's initial comments. She and I originally met when we were both doing residencies, and it was my first introduction to working with the clinical pharmacist. And one of the immediate observations that I had, and subsequently pushed as I was a teaching physician for a number of years, is that, you know, in the best of medical schools, we get 6 to 8 weeks of pharmacology training. I mean, that's all we get out of 4 years of medical school. And I've often said that if somebody is charged with making a decision of an antihypertensive medicine, anti-cholesterol lowering antibiotic, name it, who is more skilled, more experienced, and better trained to do that than a pharmacist? And I think what you're seeing is a gradual acceptance in the medical community that not only are pharmacists very capable of making these decisions, but in fact, they are far better at it than we are. And so, I've enjoyed it's kind of nice being able to roll over and tap somebody on the shoulder in the middle of the night with an on-call question, but I have really enjoyed, as our providers have enjoyed, having pharmacists on staff and being able to work with them.
I want to say something about this too, and this may not be very popular, but I think a lot of we've fought very hard to be recognized as providers, and I want us to take a step back and just not to negate the progress that we've made as provider, but I don't want to be a provider. I want to be a collaborator, and I don't want to be the one to make the diagnosis. I want to be the one who helps optimize what's going on. And while disease state management is super important, and it's been a way for pharmacists to elevate our and to practice at the top of our license, I really think that there is a difference in team-based care where we're at the right hand of the diagnostician and not solely just seeing hypertension, not working in a silo, not just seeing anticoagulation, but really going beyond that and taking care of lots of things at once, because we have that diagnostician partnership right next to it. And that may not be the most popular thing that you hear me say. I believe that pharmacy collaboration is going to allow us to actually be more satisfied professionally than we have been.
Thank y'all for that. Looks like Dr. Roman has a question, and then we'll take the question from Dr. Winslow in the chat.
Thank you, Madeline. Hi, Shannon, thank you very much. That was really, really provocative and also exciting at the same time. I really appreciate it. So I do pharmacogenomics. I'm a pharmacogenomics expert kind of thing. But I'm really curious to hear from you in terms of the infrastructure that you have to build in order to obviously utilize a test, use the CPA guidelines from GKP, whatever you use in order to basically translate the genotype to phenotype. That's one way. The other option is related to the cost. You mentioned people come with a report to you sometimes, but do you sort of order the test, and do you contract with a third-party lab to do that, or do you have some sort of facility in-house to be able to do that? Can you expand a little bit more on that? Because I'm interested in implementation of pharmacogenomics in clinical practice. That's
sure. This started because I received a broad-based panel test from someone, and I had undergone pharmacogenomic training. I wasn't exactly sure when we started the clinic if I was going to target certain drug therapies and a certain pharmacokinetic gene versus a broad-based panel. I fully believe with the mental health aspect that a broad-based panel is the way to go. We have access to order through our physician collaborator any of the broad-based panel testing. We also have a local lab that has a very small broad-based panel that is less expensive, but most of the national, the companies that Genomine, OneSite, or Ohm Health, or I can't remember the other one, but we do what?
23andMe.
Well, we can actually use 23andMe and convert it to some nutrigenomics data. We have another company that we look for hypercholesterol meds called GB Insight, and it's establishing that relationship as an ordering facility. And then usually patients will pay a copay and their insurance will kick in some, maybe not all. And so what we do when we order the test, we make it very clear what the cost of the test will be. And then for us, we provide a consultation fee, cash fee, for us to interpret the result as a part of just that one, we lump it all together. that ensures our time is compensated for sometimes very complex interactions, looking up CPICS, GKB, looking at other meds that may interact, looking at what other adjustments need to occur, or even changing medication that was inappropriately or may not be the most optimal for that patient. So it's different for each company, but in a general brushstroke, I would say we let the patient know the copay that's associated with the lab. We will take care of ordering. If a patient comes to us with a genetic test already, then they would pay us a consultation fee for us to interpret and then help them optimize their medication management based upon those results. Thanks for the question.
And then let's see, Dr. Winslow in the chat said, when speaking with providers, what are the buzzwords / things to mention that would interest a physician and make them entertain the idea of partnering with a pharmacist? That's a good question.
I'm going to think about that, and then I'm going to let my other two.
Wow. That obviously is going to differ. That answer will differ depending on the provider. I think for us and I think for my colleagues that I enjoy spending time with and have respect for, that answer probably is pharmacists in collaborative practice help us do this better and do it right. And it gives me great joy to know that we are on the cutting edge of evidence-based medicine, that we are doing the right thing for our patients. I think our patients, and we haven't even begun to discuss who our market is and who appreciates what we do, but I think that our patients really do recognize that the type of medicine and the quality of medicine that we provide is different. And the time spent, as Shannon says, but honestly, for me, I would emphasize less total time, although it's obviously very important to the patient. I would emphasize less total time and more quality of time. And part of that is establishing relationships. Part of that is just getting to know somebody and getting them to open up. That's all incredibly important. At the same time, I think it's very important to use that time efficiently and effectively. Shannon is stealing the computer again from me.
Yeah. Okay. I would also encourage you, we, as a part of the Get the Medications Right organization, we published a paper in the American Journal of Medicine. It's been within the last year on the CMM approach and how we establish the quadruple aim. That quadruple aim may be your buzzwords that you're looking for. Number one is what Lloyd just said, and that is, better care. Number two is provider satisfaction. Keep in mind the average provider has to see, so many patients, they don't have help. They only have 38 seconds to spend with patients on meds, and just knowing that a pharmacist is coming behind them and educating their patient better so that they're not going to come back into the emergency department with an adverse drug event or have issue and not take their medicine. That's a level of care that we take off the shoulders of our physician colleagues. The third aim is patient satisfaction. Patients are satisfied when a pharmacist is involved because we because we're not optimizing medications correctly. So I think that with those 4 aims, you may find a niche or someone who just needs a little help in one of those areas. I did on one of the slides too, I put an asterisk by it saying this is a pharmacist opportunity. There are annual visits that Medicare will pay for. And I know several pharmacists who are just focusing on primary care practices, Medicare patients. Now that includes an extensive drug review, but it also includes things like asking them, do you have a living will? Do you have a durable power of attorney? And there are some, there's some check marks, but you as a provider can get $110 per visit, $130 per visit, depending upon insurance. And you have to, of course, be credentialed with the insurance companies to do this. But if you focus on a high-risk group of medicine patients, i.e. the elderly, you can help your physician colleagues get more reimbursement. Your salary can be included in that. And those are models that I know are working right now for some individuals in the primary care scene.
Thank you. We've got just one more question in the chat if we have time. What is the percentage of patients in your clinic who are taking advantage of the pharmacy services? Understanding that not all patients will come to concierge medicine for the pharmacy aspect, I'm interested in how the proportion of patients utilizing this service factored into your overall fee structure to ensure you're covering a pharmacist's salary. And just real quickly, I am going to share the CE code in the chat. So anyone who's waiting on that, I'm doing that.
Yeah, I can do that too. That will help you. I think this is changing as we're growing, and coming out of COVID, we're trying to figure out who we want to be when we grow up. And during COVID, not many people took advantage of our services. Everyone was worried about sickness and acute illness, and we became point of care experts. We became counseling experts, and that was just what it was. Now that we're coming out of COVID, I would say that we're on track to, and there are spurts of time. The summer is very slow. And so right now we're not seeing as many patients as we did in the winter months, but there was a time frame this spring where we were seeing 3 or 4 patients a day, several days in a row. And that is the type of volume that I'm very pleased with. Again, our financial model is not dependent upon us seeing a number of patients per day. So I can't answer that completely with reimbursement. And every clinic is different. I know centers that are relying on a full-time pharmacist, and if they have ancillary help, they can see as many as 12 patients a day. They see fewer patients if they don't have the ancillary help, and that can support a pharmacist's salary. It's complicated. We don't have it right yet. We're working towards that. And I hope that answered your question. Oh yeah.
I think it's very difficult to try to answer that question. The reason we're stumbling with that is we've had a remarkable volume, and again, due to COVID. Don't let us underestimate how much of an impact COVID has had. And just for an example, we have marched probably just short of 20,000 patients through this very small 3,500 square foot clinic over the past 2 years. Of those, you have to understand the majority of those were for COVID testing, COVID counseling. And out of that has emerged a core group, roughly half of whom have joined as members, and the rest who utilize our services on an on-demand carte blanche kind of service. So it's of our members, comprehensive medication management is included as part of the membership benefit. So it is available to all, although because of our market and because who those members are, many do not have chronic disease state problems. But our pharmacists weigh in on every pharmacy decision that we make, and that includes the use of a particular antibiotic or approval for an antiviral and clearing, drug interactions. So it's a really difficult question to answer, and one we should be able to answer better, but we can't right now. So that's what it comes down to.
Any questions for our pharmacy resident, Alex, before our time is up?
Well, if no questions, I did have some questions, but we're already past the time. Really want to thank you guys. You're obviously very passionate and very proud of what you have accomplished. I wish you all the best and much success. The video was awesome. And I also noticed that the music was from someone in your family, it sounds like. So you're obviously a very talented family. So thank you so much for taking the time to prepare this presentation, to be with us today. And hopefully we'll see, we'll have the chance to meet in the future in person at a meeting. But congratulations and thank you so much for taking the time to spend with us today.
Thank you so much. We appreciate it.
Yes, thank you. And thank you everyone for joining today and hanging on for the last couple questions. We appreciate everyone's time. And with that, I think that's all we have. So thank you and everyone have a great rest of your day.